Good afternoon. I'm Andy Wong, and I'm going to be presenting on behalf of my co-authors to provide some insights on how we conducted COVID-19 antibody testing in the longitudinal cohorts listed here. But before I begin, I'd just like to say that this serology work package was led by Nick Timpson at Bristol and Claire Steers at King's. And this work fits in with the National longitudinal health and wellbeing theme being run by Nish Chaturvedi at UCL and Jonathan Stern at Bristol. So the national core studies were established by Sir Patrick Vallance to address key COVID areas. 6 themes were created, with the aim of this theme being to understand the health, social and economic impacts of the pandemic by using population cohorts and electronic health records to inform policy. And this slide just shows the cohort and electronic health records involved in this theme. For obvious reasons, the aim of this particular study was to investigate who in the cohort had COVID antibodies, to link these with COVID questionnaires and with the electronic health records. And we wanted to achieve this by rolling out concurrent antibody testing across all the cohorts at a single time point to participants who had completed at least one COVID questionnaire. And you can see in the images to the right, the actual sample kit was used. And these were taken from a video that the NHS had put together. You can see in the top right, this yellow tube where study members had to fill the tube up to 600. We had a fantastic response of 70%, with 33,000 kits being returned. As you can imagine though, there are a number of immediate and obvious key challenges. When we first initiated this work in November 2020 through to rolling it out in March 2021, we were presented with a number of rapidly changing landscapes. Firstly, we were facing another wave of COVID infections. We had the first vaccines being rolled out, and we had a number of test kits to evaluate and determine which was best to use. Initially, the test kits that were available were just the lateral flow kits that you can see at the top, and these ones that we're also familiar with. These simply told us the presence or absence of antibodies. Other test kits were sent to the lab in the image below. These initially targeted the nuclear protein, which provided evidence of natural infection, and the newer test kits enabled quantitative testing of the spike protein, essentially test for vaccination status. From another perspective, against the background of designing, administering, and completing COVID questionnaires, there was real concern on the burden of both study participants themselves and the study teams. And then lastly, the major challenge was administering this across a number of stakeholders, ranging from the study participants themselves, working over 11 studies, 5 universities, Thriva, the company who provided the kits, and DHSC, who was funding the rollout of these kits. So I guess, how did we mitigate this, or what did we think was the best way of working through this? Well, I think the first thing we were extremely fortunate to do is to have core funding that enabled all the interesting cohorts to participate. And crucially, there was a single point of contact to coordinate activities across the key stakeholders to identify and work through issues. And here is just a very simplistic view of data collection, where all we're doing is simply asking the study participants to complete a finger prick test and to send the kits back to us. However, when we break this down, you can see that there are many more barriers. Each study was required to have ethical approval to conduct this data collection. Each study needed to ensure that it was happy that Thriva met the necessary data securities requirements. And we had to identify how to consent our participants. Before we could even send out the kits, we had to encounter several issues that required contracts, firstly with Thriva, and then for the nursing agencies conducting data collection on behalf of some of the cohorts. And when data collection did commence, how did we deal with queries on the actual kit, the results that were returned? And lastly, how did we manage the data and store the residual sample that some of the cohorts were interested in? Well, here are a few ideas on how we dealt with the challenges and what the particular sticking points were. So the Research Ethics Committee were extremely supportive and reactive in helping to navigate the ethics process. even though each cohort still had to submit its own ethics documents, we were able to develop a single set of template documents that could be adapted by each cohort. And ethics, we set a precedent by getting an exemplar cohort submitted, and that set the basis for subsequent approvals. On the flip side, however, there were several issues in getting this approved at a local level, who themselves were swamped with approvals for other important COVID research. Due to the collaborative nature of the work, we were able to utilize PPI groups or focus groups who not only reviewed the study materials that we created, but also advised and provided thought on the use of using commercial company such as Thriva to share personal confidential information. And this focus group helped inform our consenting model. So even though we asked participants to opt in, and this caused delay in sending out the kits, it then allowed explicit consent and permitted sharing of these personal data. On the legal aspect, since we regularly engage with nursing agencies, we were able to get a relatively quick sign-off on this simple study. However, we experienced months of delay in setting up a contract both Thriva and the universities were content with. Since the COVID antibody testing was being rolled out by the NHS and DHSC, we were able to utilize their patient material and videos since they had already been written for the general population that would address and minimize queries to the cohorts themselves. And as I mentioned lastly, several of the cohorts wanted to store residual sample for long-term storage and subsequent analyses, and so there had to be several considerations in terms of how we dealt with this. So in summary, regardless of how simple data collection may seem, advance notice should really be given to obtaining ethical approval, both locally and at the rec level, but also to contracts. Bear in mind that none of us are trained in legal matters. The strength of the study really lay in a truly collaborative model. There was flexibility from the cohorts, and importantly, flexibility from Thriva, who are able to accommodate different cohort needs. The sharing of best practice and experience amongst the study member teams ensured that all possible angles were covered, and this really helped in developing template models and messages to ensure a consistent theme across the cohorts and in line with the NHS and government guidelines. And finally, not to put too fine a point on it, the financial contribution really enabled all cohorts to participate in this study. So finally, I'd just like to thank the study members themselves who participated in the data collection, the study teams for their contribution to the work, NCS for funding, and UKRA for funding NCS, and acknowledgements especially to Christine at Thriva and Claire at DHSC who really pushed forward with this, and to the field-work agencies who worked on behalf of some of the cohorts. So thank you. And I'd just like to end by asking if there are any questions at all. Thank you very much.